discuss. And now we will move to Egypt, Cairo, with Dr. Farid from Egypt, and a very interesting presentation about the new grading of epistaxis, which is carotid nasal fistula. If you have any questions, please send them during the session so we can discuss all your suggestions and questions by the end of the presentation. Thank you.
Hello, everyone, and excited to be here. And thank you for your invitation. I have a very interesting case. And it was a real nightmare. The biggest epistaxis I've ever seen. It started when a 25-year-old male, he went to surgery to remove a giant pituitary macroadenoma. And during surgery, they injured the internal carotid artery. They placed some PECs, and they transferred the patient to the angio room. And this was my angio. Everything seemed quite good. I couldn't see any pseudoaneurysms, any blushes, no nothing. The bleeding was, the injury was on the left side. As you can see here, there is some spasm. And on the right side, you can see a very good functioning echo, as it's seen here. These are other views from the left side. Also, you can see just a spasm in the internal carotid artery. No aneurysms, no abnormalities. And these are the 3D images of the left internal carotid artery. Still, I could not see any abnormality. The patient became well. They put him in the hospital for 1 week. And at the day of his discharge, he had a sudden severe epistaxis. It was so severe. It was from his left nostril. The neurosurgery attending, he controlled the bleeding. He managed to control it by inserting a Foley's catheter inside his left nostril, and he inflated it. And by the short time this happened, the patient lost a lot of blood. His blood pressure was 60/40, and his lab showed that his hemoglobin became 4 grams per deciliter. He was given blood transfusion, and he was resuscitated, and he was transferred to the angio lab in less than an hour to see what's going on. I examined him before performing the angio. He showed good flexion and good motor power in both limbs. So I decided to proceed. This was his CT before the angio. You can see the hematoma, the left side, and you can see the Foley's catheter that the neurosurgeon placed to control the bleeding. Not a very usual image you would see every day. And that was his skull x-ray for the angio. You can see the Foley's catheter on the AP and lateral view. And I performed an angio, the left internal carotid artery, and still nothing could be seen. But of course, the carotid termination was occluded. As for the right angio, the Foley's catheter was also occluding the right internal carotid artery. And it seems also it was occluding the piquants. So something had to be done. It was a very tight situation. So I placed a balloon in the It was a hyperglide in the left internal carotid artery, and I deflated the Foley's catheter, and I performed an angio. Here was my angio, and you can see the massive bleeding that was there. I'm gonna play it again. That's the lateral view. You can see how the contrast is like gushing outside his nose, and it's pouring in his pharynx. So I inflated my balloon. This is an image from the video. You can see that the bleeding occurred at the lateral segment, or the beginning of the cavernous segment of the internal carotid artery. And maybe there's another spot right here above, but it could be the ophthalmic artery. Very profuse bleeding. So I inflated the balloon, the hyperglide balloon, like you see here in the pituitary segment, and I performed an angio from the contralateral side, and still I could see the bleeding, and it's very clear on the lateral image that the bleeding occurs from the cavernous segment. In clinical life, the bleeding was so severe. When I deflated the Foley's catheter, I could see a gush of blood. A gush of blood. It was so like dramatic from his left nostril. After this, I pushed my hyperglide catheter a little bit above and inflated it, and clinically the bleeding stopped because we included the shunting point. But something had to be done. I have to place the coils, and in the 5 or 6 minutes it would take me to occlude this defect with the coils, the patient would die from the severity of the bleeding. So I decided to, that's a contralateral angiogram after I inflated the hyperglide. So I decided to re-inflate the Foley's catheter. Of course, not a very big inflation like the neurosurgeon did. And I decided to use like a mixture between contrast and saline, so I could see it and I could place it exactly next to the hyperglide balloon and next to the cella, the site of the cavernous segment. After inflating the Foley's catheter, I deflated the hyperglide balloon, like you could see here, and I performed an angiogram, and the bleeding was controlled. Foley's catheter managed to control the bleeding, and by that I had enough time to place my coils, and that's what I did. I used 3 coils. It was so quick, and after placing the coils, yep, it's occluded all right. I deflated the Foley's catheter and performed my angiographic runs, and that was it. It's a very strange case. That's what I thought I should do at that time. I don't know what else could be done. That's why I'm presenting this case here in this Nightmares conference, so to discuss it and know if there is any other possible ways of management. I'm gonna show you the first slides that I did a week before the incidence of epistaxis. As you can see, there is nothing. There is nothing. There is no indication or no sign that there is an abnormality. Thank you very much, and I'm waiting for the discussion. Thank you.
Dr. Mostafa, thank you so much for this interesting case, and it's a nightmare, but maybe yes, it's a complication from the surgery. Unfortunately, it happened to the patient, and you were trying to solve the nightmare. Actually, it's sad. But that was really interesting, because we encounter actually these cases in our practice, even more when we have a large neurosurgical activity in a hospital. I was telling Mario, now I sent him a message that we have to do a case report about the presenter in the Nightmare Summit recording from the car. That was, I guess you were very busy, and thank you for I know that it was like tight time slots for recording, so thank you so much for all the efforts.
When you get the call for work, you have to go. So,
exactly. Saving another life. That was a really interesting case, and when it happens, unfortunately, it is disastrous, because a neurosurgeon actually during the operation cannot do anything. Actually, he have no access except if he will open the neck or carotid clip, whatever, or temporary occlusion, but there is still the circle of Willis, and it will continue to bleed. So often what they do is just the huge packing of the nasal cavity, and this is not for sure a definitive treatment, and they rush always to us and call us with this cases. And you started your case by seeing something which is really interesting, and I don't think that most of any of our attendees saw it before. It's an active bleeding from the ICA and coming through the nasal cavity and going back to the patient. So this, I imagine the scene was very bloody. I can see, because when we are doing surgeries, we don't see actually endovascular treatments, we don't see any bleeding or whatever. It's just, apart from the usual bleeding of staxis, but aneurysm rupture and these things, we never see the bleeding. So I guess that was quite a scene. You started by doing a balloon test occlusion at the beginning, if I'm not wrong. And did the patient tolerate it? There was good ACOM and PCOMs, and
the balloon test occlusion in the case, like I said, this when the bleeding occurred first time, we got the patient to the angio suite, and we performed an angio and a balloon occlusion test, and he had a very good functioning circle of Willis, but we could not see any abnormality or any bleeding. Yes. So when he came back in the second time with this massive, scary bleeding, we did not perform the balloon occlusion test. We were in a rush. We wanted to save his life. Yeah, we already did it. We know he had a good. Yeah, but the problem is the inflated Foley's catheter. It led to severe spasm. I don't think his circle of Willis was functioning that well at that time. Mm-hmm. But that's why I presented the case. I saw there was nothing to do except